I have nothing to disclose except that I tend to like to be a little goofy, if you didn't get that. I'll just start out by telling you that over 25 years ago, I started working, my first job out of undergraduate school, I started working at a multidisciplinary pain clinic. And a couple of my colleagues are here today with me, a physical therapist and an occupational therapist. We also had vocational rehab, physicians, psychologists, nurses, and it's really been fun to now, 25 years later, sort of come full circle, and we're really recognizing that we really need to get back to some form of that model in taking care of this population. I went back to graduate school, got my master's degree in social work, and I started working in primary care alongside my primary care partners. And oftentimes being in the room before, during, and after these difficult conversations. And I tell you that because that is how the writings that I've done for the OPG website, as well as the talks that I've been giving locally and across the state, that work has really informed, those experiences have informed my work. I'm going to just tell you some stories, really. This is a story about leading with values. So Jim and I talk a lot about when we go into difficult conversations, it can be so it's so important to think about what is the value that's leading that discussion. So I went into a group of providers, a provider meeting that I was working in, and we like to use the analogy of a car seat. And so I was opening up to the group, how many of you have had children, or do you have children now, you have young children, and let's just imagine, you're trying to get off to work and it's your turn to take the child to daycare, and your 2-year-old is just running around, won't get in the car, and what are you going to do? I'm thinking, right, like I'm in silence, right? So everyone knows the setup. I'm asking the question, what are you going to do? I'm thinking it's something about safety, right? So they say, yeah, it's about safety. Silence. Thinking this isn't very hard. Somebody raised their hand and I said, I think I'd go get my wife. Right? That's what I would do too. I would go get my wife. And I tell that story because these are difficult conversations for a reason. We don't want to do these. We'll almost do anything not to engage in these conversations. So really important that we remember how hard this is. This is another story of a woman, a provider that I worked with a few years back, who came to me because she had had a patient that she had previously taken care of that had died of a prescription opioid overdose. She wasn't taking care of the patient at the time, but she knew that she was one of the people that started increasing the dose with this particular patient. And she said, Laura, what happened in reflection is that this patient sustained a horrible trauma when she was being cared for by this woman. And she sustained a lot of physical wounds. And they certainly warranted opioid treatment at the time. But over time, what she recognized, and in reflection, she said, I was prescribing for this patient's emotional pain as much as I was prescribing for her physical pain. She said this to me, and it was really compelling. And I think that she said, Laura, neither one of us could stand to be with the horrific emotional pain that she lived with every day. And she said, I wish that I would have been stronger in encouraging her to do some non-opioid treatment option. I talk about, people forcing. I hate that word. It's a little bit strong, but sometimes you have to do that. And that was certainly her reflection, is that what would have happened to this young lady had she been stronger in encouraging her to do some other treatment option. I call this enhanced self-awareness. This is another provider that I had the honor of working with, and hopefully I'll get the story straight because she happens to be in the audience today. And I think what her goal was really to find a way to stay connected to patients and to deliver a message around safety. And when I asked her, what she did, I took a picture of her because it was so compelling to me. And, basically she said, I just put my hand over my heart and I lean in and I say, I care about you and this is about your safety, and we need to make some changes. So these are some of the statements that we can practice and we can get comfortable with, and these go a long way in doing this work. But what happens when, right, and I've seen this happen a million times, somebody teaches themselves to do a really nice statement like that. For those of you in the back that maybe can't see this, this is a lion coming at a man, and he's trying to defend himself with a shirt. Has it ever felt like that to you in the exam room when you started to have these messages? Or this, right? Unconsolable crying. High emotions. This is really uncomfortable. Why do we want to go get the wife, right? This is uncomfortable stuff often. This is the time when I validate all of you, because I've heard so many true things about why this work is so hard. And I'm really big on validation when I work with patients, and I'm really big on validation when I work with anyone, actually. So let's just see, what are some of the things that make it hard to do these difficult conversations? Not enough time. We talked about the 6-minute hour. My friend was saying we should have a whole conference on the problem with the 6-minute hour. I agree. Not enough team support. We're getting there, but we got to get better, right? Not enough non-opioid treatment options. Or what about when you have the non-opioid treatment options, but people won't agree to go? How about, this is a hard one. This is when you don't believe the science, right? This is why today is so beautiful and that so many of you are still here this afternoon, because hopefully those of you that are questioning the science behind the safety and efficacy of opioids for chronic pain are learning something today to help that along. Tomorrow we're going to do this talk, or we're going to do our workshop. I would sort of say, if you don't buy the science, maybe don't come. Right? Go to a different workshop. There's other people that are going to be doing workshops that are going to be talking about the science. Okay, concern about poor patient satisfaction, very real, very true. We've got to work on that. And I've been saying all afternoon, discomfort with high expressed emotions. I don't know if it's happening now in medical school, but I don't think you guys are trained on how to be with people in raw pain and not have anything to offer them. Okay, yes, and here's the thing. All of those things are true, and I think what happens is you guys don't understand the power of your relationship with your patient. It is so powerful, and in these exam rooms, when I've been with providers watching these play out, I can tell you it's very real. And this is a story about Michelle Maricos, who's our person living with chronic pain, PLCP, peer specialist extraordinaire, and she came to us to one of our OPG community meetings, and she said, I want to be a part of the solution. I want to share my story. And she did, and she shared her story about being on opioids and benzodiazepines for 10 years. And at the end of the story, at the end of the night, somebody raised their hand and said, what do you think was the most important thing that your primary care provider did for you during that time? And she said, it was your confidence and your ability to walk with me down that path, and it was your belief in my ability to live opioid and benzodiazepine free. Okay, I'm going to go through these really quick. These are traps that we are organizing our talk around tomorrow. These is inspired by Brad Anderson, who's an addictionologist up in Portland. And I want you to just think to yourself, have you ever heard your patients say anything like this? Do you want me to lose my job? Or do you want me to be on the streets? We would call that a compassion trap. The all or nothing trap. So you're going to do nothing for me? Don't label me a druggie. And finally, very real, not funny, hard. Don't bother with any other meds. I'll just kill myself. When I started this, when I was working on this talk, I actually had the answers that we were suggesting, and we actually have the answers tomorrow. We have a whole sheet of answers, but I decided not to give you the answers today, because then maybe you'll come to the talk. Okay, what do I got, 2 minutes, Rachel, still? About 2. Okay, so really quickly before I have Lee come up and tell you a little bit more, what we're going to do tomorrow is we have 6 actors and actresses that are going to play patients. Would you please stand up if you're an actor or actress tomorrow? Or you're part of, okay, we have So look around. We only have 2. Rachel's standing. Okay, we have 6. Okay. These people and Lee Glass and Peter Rothfels and I are going to move people through cycles of difficult conversations built around these traps. We're going to do some demonstration, all group demonstrations of sort of core demos, and then we're going to break off in very intimate, safe groups. This morning somebody said, do I have to do a role play? No, you don't have to do a role play. I like to call it imagineering. Feels better, doesn't it? Okay. And then we're going to get back together and we're going to process that, and then we're going to unfold another trap, and we're going to talk about what's going on there for patients, and we're going to do it all over again. And I think we're going to have some fun. If you can't, right? I have another outfit for tomorrow. Yeah. So with that, I am going to actually, the objectives are in there. I'm not going to go through that because I think it's time. Right, Rachel? Okay, it's time. You're going to feel more confident. You're going to understand better. You're going to have increased awareness of your patient's issues and your own. And you're going to increase your ability to engage with patients and come up with a functional plan. Okay, now I'm going to invite Lee to come up. Lee Glass, who is the Associate Medical Director of the Department of Labor and Industries for Washington. And he goes around and has conversations with doctors and patients, and he's going to tell you a little bit about that. Do you want any of my props? No. Okay, all right.
So thank you all very much. Laura's a very hard act to follow, believe me. So with regard to difficult conversations or difficult discussions, I have a lot of slides in the handout that you should have available. And I think because of Laura's very good introduction, I'm going to skip over some of the slides so I don't just repeat some of the things that Laura said. So no financial conflicts of interest. And believe me, if you work for the state of Washington, you don't get enough money to have financial conflicts of interest. So some of the most important things that happen in medicine, I believe, happen not through surgery and not through medications, but through talking. And I think some evidence of that is in this morning's talk, we saw where nociception fits into pain and learned about the psychosocial-bio-nociceptive paradigm. And really reaching patients who are suffering is more likely to happen through a compassionate encounter with a healthcare provider than it is likely to happen on a surgery table or getting an injection. And the reason we don't more often have these kinds of conversations is, as Laura pointed out, we're just afraid. It's our amygdala that is kicking in, saying awful things can happen if you try to have a conversation with somebody who might get upset, really easily might get upset. And you could ruin a doctor-patient relationship. You could have a real bad reference in your personnel file. I mean, all kinds of bad things can happen. So why should I have this? It's much easier to just to do something else. So the goals today, I'm hopeful that you probably already are formulating an understanding of the role that difficult discussions may play in the practice of medicine. Hopeful that we'll all be able to understand some ways in which we can prepare ourselves for having these difficult conversations, and then learn some techniques that will maximize the chance that a difficult discussion is going to have a good outcome. So here's my second disclosure. This is the disclosure that's really important. Nobody's perfect, least of all me, believe me. And what follows are concepts. And most of the concepts that I'm going to be talking about, I learned through my making mistakes, and I'm a slow learner, so I made many of the same mistakes multiple times. And the odds are that we're all going to have good days and we're all going to have not such good days, and we just have to keep on practicing. So here's a case that I think has some telling parts to it. This case involves a 38-year-old woman who had low back pain for a year. She was seeing doctors at a really, really good medical institution. She was worked up to see if her low back pain had a cause that could be addressed surgically, and it was determined that she did not have that type of back pain. So she saw a physician in the center who prescribed oxycodone, more than 180 milligrams per day, and a number of other controlled substances at the same time. She was admitted to the hospital in respiratory arrest, and word of that got to my office. And part of my job is, under the Washington state statutes, we have a monopolistic state fund. And our job is not only to sell workers' compensation insurance, but also to protect the safety of workers before they get injured and after they get injured. We have safety responsibilities. So I was concerned that when I looked at this history, that this might not be the end of the story, so I sought to talk to the doctor. But he wouldn't meet with me. He said he'd only talk to me over the telephone. I talked to a supervisor, and the supervisor said, well, I really can't make him meet with you. So I talked to him over the telephone. And I told him I didn't think this was going in a good direction, and I feared that the next time he saw the patient, she would either be in respiratory arrest or dead. And he told me he had it all worked out. I shouldn't worry. He said the husband would dispense the medication. Her marriage, by the way, was on the rocks. So what could possibly go wrong with this? So 10 days later, she was found in respiratory arrest. She was resuscitated in her home by the paramedics and brought to the hospital. And so this time I told the doctor, well, you have two options. You can talk with me in person, or you can talk to the state licensing board, because that's where I'm going if you're not going to talk to me. So he chose to talk to me. And to prepare for the discussion with this doctor, I looked at he had a paper chart, and I went through the chart. I found, I don't know the exact number, I'm sure it was more than 18, while you were out notes. And every note was a reason why this woman needed her medications filled earlier than they should have been. And it was all the most ridiculous excuses, like she lost her medications, her medications were stolen, she spilled them into the sink. Every one was a different reason. And every response that the doctor had written on the note was, I explained, for example, stolen. I explained that we do not refill early prescriptions when the filled prescription was stolen. Just this time, he wrote, we will refill it. So every note, every single note, he was refilling. And she never used the same reason twice, so it didn't matter. The reason all of this happened, I am convinced, is not because the doctor was a bad person. It happened because he was afraid of having a difficult discussion, or more than one difficult discussion, because he didn't want to have a discussion with me because he feared that would be a difficult discussion too. He was otherwise an excellent doctor. He's very well versed in pharmacology. That wasn't the issue at all. So I told him that what he needed was to get training by actors who would take the role of the aggressive patient, the submissive patient, the crying patient, the seductive patient, and he would have to work through saying no in a constructive way. He said, where am I supposed to get that training? He said, I don't know, it's up to you. I'm not the one that caused all this problem. He couldn't find a place to get the training, so I helped him out. He got the training. And then we got a letter from him. And the letter, he was being monitored by a part of our agency that monitors doctors who we have concerns about. And he wrote to the person who was monitoring him and said, in his letter said, that he had taken a new job and he wouldn't be having contact with injured workers. In fact, he wouldn't even be prescribing opioids. But he got this training, and he described it as a career-altering event for him. That he felt so much more comfortable now talking with patients. And he thanked our department for having provided him with that opportunity. So tomorrow, Laura told you about what we'll be doing tomorrow. And it's an effort to try to do the same thing, to help through actual practice in a safe environment. Become comfortable having difficult discussions. So you are all welcome, and in my opinion, you don't have to buy the science. Just come anyway. Difficult discussions, by the way, can happen anywhere. It doesn't have to be in a physician-patient encounter. They can happen at home, they can happen elsewhere at work, et cetera. So it's helpful to have some techniques to deal with them. And when they don't happen, when they should, relationships suffer. They often don't happen when they should, because as I mentioned, we fear that there's going to be anger or some loss, revenge, embarrassment, something bad. Again, it's our amygdala at work there. The way we avoid them, there are some common ways. One is denial. There's no problem. It's not my job. We avoid them. We don't return telephone calls or letters. Our body language, if I stand in the doorway with half open with my hand on the knob and say, do you have any questions? Well, probably not going to have a difficult discussion. And intimidation, demeanor, the content of our speech can also let a patient know you don't want to have a discussion with me today. So an example of there's no problem. These are real examples. There was a pain doctor who was prescribing 120 milligrams of morphine a day for back pain. There was no injury. The woman just showed up and said, I have back pain. Okay. Put her on 120 milligrams of morphine a day. She was 28 years old. When I looked at her report of accident, I saw that she didn't have custody of her children, and so or of her child. So I asked the doctor, who I had gone to see because he was engaged in these prescribing practices, why doesn't she have custody of her child? Because it's unusual. Usually the mother has the custody during the week, and father, if they're separated, has it on the weekend. So this seems unusual. And the doctor said, oh, well, she had a drug abuse problem. Had. That's past tense. One surgeon told me that he would not consider talking to his patient who was a back pain patient about her history of sexual abuse, prior history of sexual abuse. Another surgeon said it's not his job to arrange for psychological treatment for a severely depressed surgical candidate. And a pain doctor wouldn't call a primary care physician regarding psychological issues. So the goals of these difficult discussions is always to build, strengthen, or repair a relationship, or maybe to achieve a healthcare outcome, such as get consent for substance abuse treatment, or help deal with the spousal abuse issue. And when a difficult discussion takes place, usually, in my experience, both parties feel good that the discussion happened, that it was needed, and a benefit occurred as a result. So what's the best time to prepare? Now, in part because who knows when the need is going to be for the next difficult discussion. There are three major categories of preparation, and what I'm going to do now, because we're so far behind schedule, is rather than go through all my slides, I'm just going to leave this slide up and talk about these three areas. And we'll try to get a little closer to on time. So preparing oneself for difficult discussions is, I think, a really important factor. And the most important thing, I think, is to ask ourselves, what are we doing and why are we doing it? And as Laura pointed out, safety is usually the concern. It's a concern, and as I think it was the senator who pointed out, the reason we're here is because we're trying to help people. And as Laura points out, we're trying to keep them safe from some really potentially deadly consequences. And I think when we see that in ourselves, when we recognize that that's why we're here, why we're doing what we're doing, then we can be confident that when we talk to patients, that we're going to be able to make it through this discussion okay. Patients, as Dr. Taubman pointed out this morning, when they're in distress, they're hypervigilant. And I think that when we are honest with ourselves and with the patient as to why we're doing this, they can tell. This is coming from an honest place. And as long as they can tell that it's coming from an honest place, we're off to a good start. So I think the first thing to do is for us to articulate to ourselves in our own way why we're doing that. As Dr. Taubman pointed out this morning, setting expectations is really, really critical. Those expectations may vary patient to patient, discussion to discussion, but it has to be really clear what they are. And there needs to be agreement, articulated agreement, verbalized agreement by the patient to accept those expectations. Logistically, there are three things that I think are really important. One is comfort. Two is safety in a different way than I've been using the word before. And the third is respect. So, with regard to respect, it is vitally important that the patient feel that the reason this discussion is happening is out of respect for the patient's needs. Again, when patients who are hypervigilant sense that that's what's going on, they'll be much more receptive to hearing the message that we're trying to deliver. With regard to safety, I don't mean safety in this sense with regard to how many milligrams of an opioid, but rather that this encounter is safe, that the conversation is a safe thing to have, that the patient doesn't have to be fearful that the conversation itself will be harmful. So it's important, I think, to through both words and through the process of having the discussion, that safety be considered in a very high priority. It may be necessary to say to a patient, I really feel that we need to talk about whatever it is we need to talk about. I'd like you to think about some issues of that, and let's get back together again at a time that's convenient for you, so we can talk about this further. And if you have concerns about talking about this topic, let's say it involves spousal abuse, for example, let me know, and we'll try to work out something that, to be sure that you're feel as safe and as comfortable as possible. And then finally, comfort is a third element. And by comfort, I mean in part physical comfort. If a patient is gowned sitting on an exam table, they're probably not going to feel real comfortable having a difficult discussion. So there's physical comfort and then also psychological comfort. I think it's really important that the patient feels that even though the discussion may be about difficult subjects, it feels that the healthcare provider is making me as comfortable as I can be made under these circumstances. So those are I think the key elements. And I will stop here. And if there's an opportunity for questions later, I'm happy to answer any questions.